Good evening, everyone. My name is Michelle. I'm a product specialist here at Oculus. Welcome to tonight's clinical webcast, BostonSight SCLERAL Lenses and Pentacam CSP. You have a text box on your GoToWebinar screen where you can enter questions. Feel free to enter your questions at any time, and we will discuss them at the end of tonight's webcast. Our speaker tonight is Dr. Ellen Shorter. Dr. Shorter graduated from Illinois Wesleyan University in Bloomington, Illinois, with a degree in biology in 2005. She earned her Doctor of Optometry from Illinois College of Optometry in Chicago in 2009. Dr. Shorter completed her residency at the Jesse Brown VA Medical Center in Chicago, Illinois, and at the Blind Rehabilitation Center at Hines Veterans Hospital in Hines, Illinois. In 2010, she completed the BostonSight Pros Clinical Fellowship at Boston Foundation for Sight. She has completed the Scholars for Teaching Excellence Faculty Fellowship at the University of Illinois and is a Fellow of the American Academy of Optometry. Currently, Dr. Shorter is an Associate Professor of Ophthalmology at UIC. She specializes in medically necessary contact lenses, management of K-Pro bandage lenses, and pros for the management of severe dry eye. I'm excited for tonight's webinar. Thank you, Dr. Shorter.
Thanks, Michelle, and thanks everyone for joining us tonight. I'm really excited to talk about something that I work with a lot, which is the BostonSight SCLERAL lenses, and particularly their use with the Pentacam CSP. So in my practice, I've been working with BostonSight for more than 10 years, fitting both pros lenses and the BostonSight SCLERAL lenses. I've been able to help hundreds of patients who have ocular surface disease and severe ectasia using their lenses. So my practice is made up primarily of ocular surface disease. I see a lot of patients with Sjogren's syndrome, Stevens-Johnson syndrome, graft-versus-host disease. And I also see patients with corneal ectasia, post-LASIK ectasia, patients who've had injury or trauma to their eyes. About 2 years ago, BostonSight approached me and asked if I would be interested in beta testing this new technology, utilizing the Pentacam CSP, and I jumped at the chance. I was really excited to try this out in my practice. So the goals tonight are go over what is the BostonSight Smart 360 lens design, how do we obtain a Pentacam CSP scan, and then how can we use the BostonSight Fitconnect software to design a freeform lens. I'll go over a couple examples and how I organize my clinic to see these patients for their dispensing visits and their follow-ups. So first, what is the BostonSight SCLERAL Smart 360 lens? So the BostonSight Smart 360 lens is a truly free-form lens design. It utilizes the corneal profilometry data in order to create a customized fit for each unique patient. The ordering process can be done easily using their website, the Fitconnect ordering program. You can design lenses from 16 millimeters up to 19 millimeters. The benefits of this lens is it can be fit with the exact shape to the eye, which will allow it to be rotationally stable. It's really important that a lens design be stable when we work to incorporate optical toricity to include cylinder overrefractions to maximize visual acuity, and also if we consider incorporating higher order aberration correction. So thanks to Dr. Denier and the Scleral Shape Study Group, we all are pretty familiar with this data now, that the majority of eyes are either asymmetric or have either asymmetric or irregular scleral shape. So most patients could benefit from either a quadrant-specific scleral lens or a freeform lens design. Additionally, their work looking at patients with corneal irregularity found that even a higher percentage of those patients had irregular scleral shape. So when we think about the patients that come to see you for scleral lens fitting or scleral lens evaluation, whether they have ocular surface disease or dry eye where they have semi-regular corneas per se, the scleral shape can still be irregular and they could still benefit from this, from using a freeform lens design. So next, I'm going to explain how you can obtain the Pentacam CSP scan. So this is an anterior segment tomographer, which allows us to get a 2D image from a 3D object. It utilizes a rotating Scheimpflug camera. to capture 250 Scheimpflug images. With this model, we can capture up to 18 millimeters onto the sclera. And included in this data, we can also get all the information from the corneal scans as well. So we can see the SIMCs for the anterior surface, look at the posterior float, and monitor patients for progression or diagnosis of ectasia. We can also utilize, evaluate the pachymetry readings, so we can evaluate graft health or how patients are doing after using scleral lenses over time. So when you're getting started and thinking about obtaining CSP scans, one of the most important things you can do is make sure that the Pentacam instrument is located in a location where you can fully darken the room. When I first got started, we had our Pentacam kind of in a walkthrough area. And I can say that since I've moved it to a new location and we're able to fully dim the lights and have a private area, scan quality has definitely improved. It's not required, but in my practice, I tend to use topical anesthetic. It helps the patient maintain fixation, and it helps me as the examiner be able to manipulate the eyelids if needed. There's no fluorescein needed for this scan. You could also use preservative-free artificial tears to ensure that the patient is more comfortable. In the beginning, I definitely recommend using 2 examiners. One can align the patient and move the instrument around, while the second examiner can help the patient maintain fixation and manipulate the lids as needed. I typically have the patient maintain with their chin in the chin rest and forehead against the forehead rest for the entire scans to limit the need to have the patient move, read back, and completely refocus. But between scans, I'll have the patient rest and close their eyes. It's also important during the scan process to check for errors and repeat scans if necessary. Some of the errors that you can watch for are alignment error, CSP fixation insufficient, unsteady fixation, which I'll be able to show you an example of, as well as blinking error. If you can see any of these errors, it's better to pause, rescan that area, and then move on once you have a little bit better quality data. It's really important when we're trying to use the CSP data that we have quality data to start our lens design. So next I'm going to walk through exactly how you can obtain the CSP measurement. So this is the entering screen you'll see if you're going to scan a patient. So in my practice, typically we're doing corneal scans. So I have to make sure that we change the scan option from 25 pictures per second to the CSP 5x50 pictures per second, 2 seconds. And then we're going to position the patient in the instrument. And you could see here that there was a lid stick, so almost like a cotton tip applicator, but with an adhesive end. Oculus has, they sell the lid sticks, which are really helpful for holding the upper eyelids. And then you can see as we get the patient into position, we tell them to maintain fixation, and we can, oops, let me go back here. Start over. We're getting the upper eyelid out of the way, and we'll be able to obtain the central scan here. It'll auto capture. You can review the Scheimpflug images, check for blinks, check for coverage. Is a successful scan, so we can accept and move forward. Next, we'll go to a nasal scan. The patient stays in primary gaze. Again, we can hold the upper eyelid, have the patient fixate. And here you're going to see that the patient had unsteady fixation. That blue circle is not within the larger blue circle. So instead of accepting, we're going to rescan. And you see we have a successful scan. We'll repeat this for the nasal, for the temporal area. Check for scan coverage once it comes through, as well as fixation. Repeat this for the superior scan. And then here for the inferior scan. Once we accept that, we'll move forward into the CSP report. So this is what's going to give us a lot of information, as well as we can always toggle back and look at the four-maps refractive to look at the corneal shape and look for corneal ectasia. But a little bit more on the CSP report. So one of the first things you can look at is the QS or see if there's any errors. So up in this area here If there's a yellow warning in the shading or a red warning in the shading, it may tell you that there was a blinking error or other issues that may need to be addressed if you want to consider rescanning. But in the left section here, this is the corneal scleral profile. And so this, you can see, uses the data obtained from the 5 scans. Each section is color coordinated based on which scan it was obtained from. You can toggle over it and you can display the sagittal height for each section. As you move to the center of the report, you can see the coverage map. So this is what we were seeing as we went through the scan process. But it's, like I mentioned, it's really important that the patient maintains fixation. So when you're looking at the colored dots within the colored circles, you want to make sure that the patient maintains steady fixation and that they're within those larger circles. You can also get an idea about how much coverage you were able to obtain. So for each quadrant, you can see how much coverage the scan had. True data will be solid or solid line, and extrapolated data will be represented with a dotted line. In the middle, you can also see the horizontal white to white. So for this patient, they have 11.6 millimeter. This will be important as we go forward and we're designing our freeform lens design. And then in the bottom right, this is kind of one of the most important sections here. This is the corneal scleral elevation. So this section here is going to give you a great idea of what the overall scleral shape is and guide you to whether you're going to go with a toric landing zone, a quadrant specific, or a freeform lens design. So the way that it works, there's a best fit sphere calculated for the corneal section, as well as a best fit reference sphere calculated for the scleral section. And it's an elevation map. So any areas that are shaded red are steeper than the reference, and any areas that are shaded blue are more shallow or flatter than the reference. So in this example, the patient has scleral toricity that is oblique in nature. And then another thing that you can do here in the top portion is you can select your ring diameter or which chord you're interested in. So I typically try to go with a larger diameter, as I'm usually fitting larger diameter lenses. But with this, we could also go down to a 15 or up to a 16. And this will tell us the bulbar slope for the 2 primary meridians, as well as the sagittal height. So additionally, Oculus has a new instrument that's the Pentacam AXL Wave. So this instrument utilizes the same Scheimpflug technology, but is able to capture up to 20 millimeters of the ocular surface with a single scan. Additionally, it can measure aberrometry, axial length, retroillumination. And so I'll go through this example as well. So there's a similar auto capture once the patient is in proper position. The lid is manipulated out of the way with a lid stick. It'll auto release once you're focused. With the CSP Pro, we can review the Scheimpflug images. The first 25 have a brighter illumination, which focus on the cornea. The second 25 have a lower illumination, which highlight the scleral area. We can go to display CSP report. And here we can load the CSP report for the patient. And of note here, look at the coverage maps. Instead of having that rainbow colored coverage map where we are splicing together more than one scan, this coverage map shows that it was obtained all with a single scan. It's all the same yellow color. Okay, for the next section, I'm going to talk about how we can design freeform lenses using the BostonSight Fitconnect technology. So we've already done the first portion. We were able to obtain a CSP scan for our patient. So the next step, we're going to talk about how we can send that data directly to the lab to design a custom lens, and how we can select from any of the diameters between 16 to 19 millimeters based on the patient's condition and their needs. So some things to think about when we're selecting the diameter for our patient. We can think about the underlying condition. For patients with ocular surface disease, I tend to go with a larger overall diameter to provide more protection on the ocular surface and more relief from their dryness symptoms. We can also use a larger diameter when the patient has a larger HVID or when they have chronic exposure, like exposure keratitis. Additionally, patients that have severe ectasia or very steep SIMKs, it can be helpful to go with a larger overall diameter so we can distribute the weight of the scleral lens a little more evenly and improve the comfort for the patient. Other cases are patients that have corneal grafts that are older. We may fit a little bit larger, a little bit looser to ensure that we're not placing additional stress on the cornea. And smaller diameters can also be very useful. In my practice, I use them for patients that have smaller HVIDs or those who have small, tight lids or prior eyelid surgeries. Additionally, for children or patients that are very timid, very nervous about the application and removal process, we can start with a smaller diameter and then work up to a larger diameter in the future if needed. So the process is really simple. If you've worked with the BostonSight SCLERAL lenses in the past, you'll log into the same Fitconnect system. If you have not used Fitconnect in the past, it's really user-friendly and BostonSight can help get you set up. So under New Order, we'll select the Smart 360 lens design, and we'll select which eye we're going to use, right or left. And then the next prompt will have you upload your CSP data that you've already obtained. So we'll select the Pentacam device, and then we'll select the appropriate scan for that patient's eye. The next is our opportunity to customize the lens design. So on the screen, we're able to first select the diameter. Again, we can choose between 16 and 19. This can be based on the patient's condition or how the quality of the scan data you were able to obtain during your CSP report. The base curve, this is done for you. It's automatically calculated based on the patient's corneal shape. You can select the corneal clearance that you would desire. The HVID you can enter from your Pentacam data, and then the vertical iris diameter as well. And the next portion is where we determine which power we want to use. So we have three options when we're determining the optics for the patient. The first option is what I use the most often. If the patient is new to scleral lenses and we're not sure about the visual potential or we're not sure about which diameter I'm going to use, I'll place a BostonSight SCLERAL lens, trial lens directly on the patient's eye and complete a sphere sill over refraction. If the patients have a small amount of cylinder, I'll often start with a sphere. Another really great feature of these lenses is that we can adjust the eccentricity value. So I'll typically start with an FSC or eccentricity of 1. Most patients do really well with that, but in some cases, patients with more regular corneas do better with an eccentricity of 0, or patients with more severe ectasia, they can achieve a better acuity with an FSC 2. The second option, you can enter the power and the base curve and over refraction from a known gas permeable lens. So this is a great option if you're refitting a patient from a different type of scleral lens and you know the data, or if you're refitting a patient from a corneal gas permeable lens. And the third option, just enter the power and the base curve that you would like, and it'll automatically calculate your lens optics. And then the last option is choosing your materials and whether you'd like the tangible hydropen coating for that patient. So I'm going to quickly go through this example of how I did the order. So I'm using the patient that I showed you earlier, the CSP scan I obtained for the left eye. So we're going to select the Smart 360, left eye, start order. We're going to choose the Pentacam device. I've already loaded the proper scan. So here I'm going to move on to diameter selection. This patient has a pretty normal cornea. I'm going to choose a 17 millimeter. The base curve suggested was a 7.81. I'll usually stay with the suggested base curve and choose a corneal clearance of 300, enter the HVID of 11.6, 11.5 for vertical. When you click recalculate, you're going to see a graphical representation of the proposed lens design. I think it's a little tight in the mid-peripheral there, so I'm going to flatten the base curve. You can adjust the base curve if you'd like. Just remember to recalculate, and you can see I have a little bit more mid-peripheral lens clearance. If you're happy with the design, you could move over to the lens optics section. For this patient, I put a scleral lens on, -175 sphere over refraction with an eccentricity of 0, gave her the best quality of vision. We can click calculate, and the calculated lens optics will automatically be updated, -1.45 sphere, base curve 8.01, eccentricity of 0. I'm going to choose the material of optimum extreme and HydroPeg coating. And at this point, we click save, submit, and it will be directly transmitted to the lab. So I found this technology is really helpful. Sometimes I save more difficult orders for the end of the day and the charts pile up. But with the Fitconnect, I feel like I can do this and it doesn't interrupt the flow of my clinic. If you're not familiar with the BostonSight lens markings, it's important to know that the right lens will have a single dot that should be oriented up, and the left lens will have 2 dots that should be oriented up. It's important that the patient be instructed on this at the dispensing visit, as well as the technicians or any staff that are helping do this, so they can instruct the patient correct from early on. Additionally, the lenses have markings of the quadrants, 1, 2, 3, and 4 as you go clockwise around. They also have the lens order number, in addition to the first 3 letters of the patient's last name and the number of the lens that was cut. So the patients, if we're doing a brand new order, it'll have the first 3 letters of their last name with the number 1 if you design the right lens first, and the first 3 letters of their last name with the number 2 if you design their left lens second. This is really important when we're mailing lenses to patients. I feel really confident mailing power changes to patients when I'm using the freeform design, but it's important that when they return, you ensure that they're wearing the proper lens and you're collecting the older lenses back. So in my practice, I always have the patients return for a dispensing visit. If they're existing patients, it's a little bit quicker of a visit. It's a quick check at the slit lamp. We'll make sure that the lens is clearing the cornea, clearing the limbal area, and that the scleral landing zone is adequate. For patients that are new to scleral lenses, I'll do the same check the vision over refraction, and then we'll complete application and removal training that day. It's important that the staff train the patients which solutions and which cleaners to use. In my practice, we provide a handout with the colored, printed out examples so the patients start out with the right solutions and the right cleaning systems from the beginning. It's also really important, although we're fitting the freeform lenses and we know that they're going to have very well aligned scleral landing zones, it's important that we see these patients back for follow-up. I typically schedule my patients back middle of the day or end of the day. On the day that they're coming to see me as a follow-up, I'll instruct them to put the lenses on very early in the morning and leave them on without removing them until I see them in the clinic. In clinic, I'll do a slit lamp exam, check vision, and then I can't stress this enough, always remove the lens to check the health of the cornea and the ocular surface. If there's staining or impression on the conjunctival surface, or if it's difficult to remove the lens, like there's suction, there's a lot of adaptations that we can easily make to lens design. We can flatten the scleral landing zone. We can incorporate channel technology. So it's really important that we're seeing these patients back and that we're checking the health of the eye with the lens removed. So next, I'd like to go through a couple of examples of how I've been able to use these lens designs in my clinic. So the first patient was a 55-year-old woman. She had a pretty unremarkable history of myopia with presbyopia. She used soft daily lenses for years, mainly while exercising. No history of eye injuries, eye surgeries, no systemic problems. Only time she said she'd been in the hospital or ever taken any prescription medication was when she had C-sections to deliver her children. And so in the fall, she had flashes and floaters, and she was diagnosed with a retinal tear and treated with laser treatment in both eyes. Immediately after that, she developed sudden onset dryness, severe eye pain in both eyes. She was no longer able to wear the soft contact lenses at all. And this woman traveled the country. She went to 2 of the most premier ophthalmology practices in the country, was seen by specialists, underwent many, many tests, and ultimately was diagnosed with neuropathic eye pain. So neuropathic eye pain can be a really difficult condition. The normal stimuli like moving air, wind, blinking, all these things that should normally not cause any irritation or pain can cause excruciating pain. So she was managed with many of the traditional dry eye therapies, including preservative-free artificial tears, autologous serum, steroid eye drops and ointments. And she was even using oral agents like hydrocodone and pregabalin. So overall, her entering visual acuity was 20/20 in the right eye, 20/25 in the left eye. And the slit lamp exam was really pretty unremarkable. Maybe a reduced tear breakup time, but overall, no staining, no keratopathy at all. So one of the markers of corneal neuropathic pain is when the patient's symptoms are much greater than the patient's signs. So in this case, her OSDI screening, she was in the severe disease category. She had a score of 68, and she did have some inflammation on the surface, MMP9 positive. The corneal scans of the Pentacam were very regular, very normal, SIMKs in the normal range. So we talked about options. Again, this patient had traveled all over the country. She'd done her research. She knew all about all the options. I talked to her about diagnostic lens fitting and how we could trial lenses on, have her return, check the fit, and so on. I also offered her image-guided freeform lens design, as well as impression-based lens design. So after discussion, we decided to go ahead and obtain the CSP scans. So for her right eye, this is her scan. So we can see here she has a horizontal white to white of 12.1, so a little bit on the larger side. This would guide me to wanting to go to a little bit larger overall diameter. And you can see here the coverage map, not quite as good as the example I showed earlier. There's a little bit more extrapolated data. You can see that with the dotted data lines. And the corneal scleral elevation, you can see that she does have irregular scleral toricity. And left eye, similarly, you can see that she also has that oblique irregular scleral toricity as well. So we decided to go with the freeform lens design. And to determine the power, I use the BostonSight SCLERAL fitting lenses. I usually will start with something pretty standard right in the middle with an 18.5, 3000 sag, the standard scleral landing zone lens first. This one has the eccentricity of 1. And with these lenses in the right and left eye, we were able to achieve an over-refraction with a spherical power 20/20 in both eyes. So using that data, I was able to design her first set of lenses. And you can see here, the outcome was really excellent all the way from the beginning. So I used the Optimum Extreme with HydraPeg to try to improve her comfort as she was blinking, anything to help her have some relief. The base curves were pretty similar between the right and left eyes. I went with a very large diameter, 19, to provide more protection. And the sagittal heights are automatically calculated from your scans. And she achieved 20/20 vision. So it's not the end of the story with her. I mean, she's still dealing with her eye pain, but I'm really happy that I was able to use these freeform lenses to help be part of the tools that can help her heal and help her feel better. And then a second case, this is a 45-year-old woman who had a history of exposure keratopathy. Her history is interesting. She had an injury where she was hit in the eye with a tennis ball. And so she saw an oculoplastic surgeon, asking them for surgical options, and she had ptosis repair. She had a second ptosis repair with a second oculoplastic surgeon, and by the time she came to my academic medical center, there was imaging ordered, and the MRI revealed that she actually had an orbital apex tumor. So as part of the treatment, they had to do a large resection of the tumor, which involved damage to the levator muscle as well as extraocular muscles and required a bone graft. So as you can see here, this is about how she looked when I started. She has a large amount of leg ophthalmos and diffuse keratopathy. The vision was better than expected. She was lubricating, every 5-10 minutes, and her vision was 20/30 in that eye. She'd already undergone 6 different eyelid surgeries and wasn't a candidate for additional surgeries at this time. So this woman is a really busy working professional. She's got young children. And so we talked about the different options, but we wanted to really have the best outcomes we could have with the least amount of office visits. And so we went ahead with a CSP scan for her as well. And as part of her management, we also talked about nighttime protection. So for any patients that have this leg ophthalmos or exposure component, it's really important to think about both daytime and nighttime protection. So we talked about using lubricating ointment, taping the eyelid shut, and as well as moisture chambers. And so this is her CSP report. Again, not quite as perfect as the scan earlier, but we were still able to obtain really quality data. You can see from the coverage map, there was a little bit of extrapolated data superior. And on the corneal scleral elevation, we can see that the patient has scleral toricity. So with the first lens, I was able to order using optimum infinity material, 8.65 base curve, a large 19mm design with a 25/68 sagittal height. And she was really happy. She was able to wear this lens all day long. She could wear it from morning to evening, and vision was really good. But sometimes good is not good enough. And so this patient would have episodes of pain upon awakening. So despite her lubrication and the protection of her eye overnight, she was still waking with pain at least a few times a month. And so after consultation with her oculoplastics surgeon, we talked about different options for nighttime protection. And so one of the options that was discussed was extended wear scleral lens use. So this isn't something that I take on lightly. We had a long discussion with her cornea specialist as well as her oculoplastic surgeon about the risks and the benefits. So in this case, we talked about risk of hypoxia to the cornea, risk of infection, but the patient was really adamant she wanted to go forward with a trial. So we decided to go forward with a 12 and 12 wear schedule. So she would wear the daytime lens during the day, and then I made some modifications to the freeform lens design so that she could use it overnight. So for the nighttime lens, I kept the high decay material, and I lowered the total seg, so there's a little bit less central clearance. I loosened the scleral landing zone to eliminate any component of suction, as well as adding channels. And as part of this management, I told her that she was going to need very close follow-up. So the first evening that she wore it all night, I had her return to see me in the morning so that I could be the one to remove the lens, check her corneal health, as well as the corneal pachymetry. So this is something that she uses not every single night, but probably 2 out of 3 or 3 out of 4 nights a week. But again, good is not always enough. And so if you look at this picture here, you can see this is lens that has a little bit more sagittal depth than we would normally shoot for. And this is intentional. So the patient really wanted additional eyelid surgery, but she's a poor candidate due to all the scar tissue and the prior surgeries that she's had. And so again, in consultation with our corneal specialist, and the patient really advocated for this, we designed a daytime lens with a higher amount of total seg. So this gives her a little bit more eyelid lift and improves her function and her cosmesis. So overall, we went over how to utilize the Pentacam CSP technology, how we can integrate this with a freeform lens design with BostonSight, and how we can use this to maximize our patients' visual acuity and comfort. So this technology can be used for new patients. So if patients are coming to you for a new scleral lens evaluation, it's a great time just to obtain a scan from the beginning, take a look at their scleral shape, and decide from there would they benefit from freeform design. Additionally, this is something that I offer for patients when I'm troubleshooting fits when they come in from elsewhere. Something I want to highlight is if a patient comes in wearing a small and a tight scleral lens that they have discomfort with, it's important not to obtain the scan that same day. It's better to do a washout period and have them not wear the lens the day of the scan, and preferably a couple of days if it's a very tight lens design, so that you can have a high quality scan on the day that you start the fitting process. And this is also something that I offer to patients who, in my mind, are stable, successful lens wearers. So even the patients that aren't complaining, if they're coming to see me for a follow-up visit for either their 6-month check or a yearly check, and it's time to order a new lens anyway, or for example, a patient's undergoing cataract surgery, and we know that we're going to need to incorporate the updated optics into their new lens design, I let them know some of the technology we have available, some of the options we can provide for them. And oftentimes I'm surprised myself that patients I thought were doing just fine will be even happier, have more wear time, have better comfort. So with that, we can open it up to any questions. Thank you.
Thank you so much, Dr. Shorter. Just a reminder, on your GoToWebinar screen, there is a text box where you can enter any questions you may have. If you miss part of the webinar, or if there's anything you would like to go back and review, you will receive a link to the recording in the next week. All right, we do have quite a few questions that have been submitted, so I'm going to go ahead and start asking. One of the first ones I want to ask, if you have a new user coming to the BostonSight Smart 360 software, are there any education materials, webinars that you would recommend to a beginner / intermediate user?
Yeah, absolutely. So BostonSight, you can reach out to the team. They have resources on their website. They have how-to guidelines on their website as well. So if you do better with a step-by-step guideline, some of the screenshots that I shared with on how to start the lens process was directly from the website. So BostonSight is incredibly helpful. I didn't mention that enough, but everyone who works in the lab, all the different employees and all the doctors are incredibly helpful. So if there's challenging cases that come up or you need help getting started, just don't hesitate to ask. You can reach out to BostonSight directly.
Great, thank you. Do you use aberrometry to help guide use of the FSC?
So in my practice, I don't have an aberrometer that's very close to my practice. So if I want to do aberrometry, I usually have to plan ahead and go to a separate clinical area. So the way that I use the FSC determination is really simple. I just kind of go about it in a pretty practical way. So I'll often start with the FSC1, which works for, I would say, the majority of my patients. And I'll do a simple spherical over-refraction. If I don't achieve the vision that I think that they should have, I'll add a sphere cylinder over refraction to see if we can fine tune the visual acuity and visual quality. And if I'm still not achieving the vision that I think that they should obtain, I'll switch to a different trial. So I'll just go ahead and quickly put on the FSC 0 lens or an FSC 2 lens.
Great, thank you. Is BostonSight the only manufacturer that makes larger than 18mm freeform lenses?
I don't know, that might be a better question for you, Michelle, but I think there's quite a few, there are quite a few manufacturers that are utilizing the freeform lens design. So I think that the Pentacam can communicate and integrate with other manufacturers as well.
You are correct. Do you mind elaborating on the diameters that BostonSight can do again?
Yeah, so with the BostonSight, when you look at the fitting sets, so if you don't have their fitting sets, I really recommend them. So the BostonSight SCLERAL lenses come in a 16 to 17, like a smaller diameter lens trials. We have 16, 16.5, and 17. And they have a right eye as well as a left eye. And so you can start with the lens designs. They have different sagittal heights if you need more or less clearance. And they also have different landing zones of steep and flat. So this can give you an idea if you're designing the freeform lens design, what size you want to do. They also have a larger size, which goes up to 19 millimeters. So 18, 18.5, 19. And so it's really helpful. So you can put them on the patient. You can get an idea of what size is ideal for that patient.
All right, I feel like this question's a good follow-up to your answer before. I'm just getting started with the new Pentacam CSP, and how do I image past 18 millimeters if BostonSight goes up to 19? But I'm going to kind of elaborate on that question. Dr. Shorter, could you explain how you might use the lower diameter information that you get from the Pentacam and how you approach fitting the larger diameter BostonSight lenses? So how you use those sagittal heights that you might only get out to 17.5, let's say.
Yeah, so I mean, when we're using this freeform lens design, you know, the data that we obtain even out to 18 millimeters, or in the case of the examples I showed, we didn't even quite get out to 18 for all of those patients, and I was still able to design the lens just in the pretty standard way. So I would just, I guess the determination to go larger is clinical, but the ability to design it larger is really simple. It's worked really well where the data that you obtain up until the diameter can still be extrapolated by the lab to come up with a larger diameter lens.
Great, thank you. And what kind of patient can benefit from a higher order aberration optimization?
So when I was talking about, you know, any patient that you don't think you're getting the acuity that you think you should. So if a patient has keratoconus and the media and the cornea is pretty clear and you're only obtaining, you know, 20/40 or a slow 20/30, this would be a great example of a patient with ectasia that you think that because the cornea is clear, they have better potential. So this would be a case that I'd take the extra, you know, 2 minutes, put a different scleral lens trial on with eccentricity 2 or eccentricity 0. And if you're really tight for time, it's something that you can do when you're incorporating a power change as well. So you could simply, on your next rendition, if you're making a slight change to incorporate a small over refraction, you could also adjust the eccentricity so you can evaluate it clinically as well as have the patient let you know their preference.
Thank you. And can you explain your patient flow from Pentacam to Smart 360 software? Do you do the scan and have the patient come back later, or is it all kind of in one day?
So in my practice, it's probably not the most efficient. I guess I think that in an ideal situation, it'd be really great to have the patient in for an initial consultation. And as you're meeting them, I think it'd be really helpful to obtain some of the baseline data, maybe your standard tomography data, looking at the cornea shape, and discuss with the patient what they've tried before and what they've failed. And at that time, I think it'd be nice to have them scheduled to come back on a new day. That way, if they're wearing any type of lenses, you can ask them to just wear their glasses in or have someone drive them into the visit so you can obtain the scan on a day when they haven't had any lenses on the eye. But in practice, I would say that it's not always like that. I have a lot of patients, like the first case, the patient drives about 3.5, 4 hours to come see me. A lot of my patients come from a distance. And so in those situations, I'll do the best that I can. So oftentimes it's not the most efficient, but sometimes at intake, they've already done the screening corneal scans. And then after I've seen the patient, I'll decide that I want to go forward with the scan. Either I like to do the scans. I think it's really important, especially in the beginning, that you know that you're accepting a high quality scan and you're repeating areas that need to be, because there's nothing worse than, you know, telling your patient all about this great technology and then having a poor quality scan where you can't actually order from. So that's one other tip I would say, just to elaborate too, would be while the patient's still there, I do like to save the data, go directly into Fitconnect and try to process it and make sure that I'm able to go forward and place the order, that the lab has enough data. So it does add a little bit more time to the initial visit, but I think it is worthwhile. The outcomes, I've been really impressed, you know, it does take some practice to improve your skills to obtain high quality scans and make sure that you're not getting errors that can be prevented. But I've been really impressed with the outcome of these lenses and how well they have aligned with the conjunctival tissue.
Fantastic. Please address how you use the CSP and its sagittal height feature to determine the best diagnostic set lens to apply for over-refraction.
So I don't even do this as specifically, and sometimes I actually do the over-refraction beforehand. But if you're not sure where to start, you can always look at the top right corner of the CSP report, and you can get an idea of what the sagittal height is for that cord. So if you're not sure and you're not too sure, you can always look there for some guidance. But with the BostonSight SCLERAL lenses, or you can use a corneal GP lenses. I mean, there's limitless options of how you get your over-refraction to start. But with the BostonSight SCLERAL, even when I'm doing an over-refraction to determine the power, I'm not overly concerned about the fit. I'll take a very quick look, make sure that there's no bubble, make sure the front surface of the lens is wettable enough. And I don't worry too much because I know that we'll be able to get an over-refraction, that we're not using that for the fitting data.
Thank you. And our next question is, how would you approach first fit, best fit using the Pentacam and the Smart 360 software?
So I think when we think about having this data available, so when we have the Pentacam CSP data available, I think it's a really great option. So if we use that data to design a freeform lens, at worst case, you have a custom scleral trial that you're using to go forward. So I think it's really a great option to provide for patients to get the best fit with the very first lens that you provide for them.
All right. I wanted to thank you, Dr. Ellen Shorter, for that great presentation. That's all the time we have for tonight. Thank you for everyone who sent in questions, and thanks everyone for joining us this evening. Do you have any last thoughts, Dr. Shorter?
I just want to thank everyone for taking time out of their evening. I know it's a busy month, but if you have any other questions or if there's anything that I could help with, just feel free to reach out to me. You can email me.
All right. This concludes the presentation on behalf of Oculus. Good night, everyone. Thank you.
Thanks.